So we're just going to briefly introduce ourselves. I'm Jason Altenberg. I'm the Director of Programs and Services at South Riverdale Community Health Centre, which is one of the partners in the Toronto Community Hep C program, along with Regent Park and Sherbourne Health Centre. And amongst other things, our focus is on drug user health and access to hepatitis C supports for people who use drugs. So that's who I am.
Thank you. Good morning. My name is Renee Mashing. I have bloodlines from Six Nations of the Grand River in Southern Ontario. I live in Nova Scotia now. I'm also of Irish descent, and I was adopted and raised in a family of Western European descent and first-generation Canadian Eastern European descent. So I bring those perspectives with me. I'm also the Director of Research and Policy with the Canadian Aboriginal AIDS Network. So just to begin our day in a good way, and thank you so much, Jordan, as well, for the acknowledgement of the land territory. And I grew up in this territory, but I live now in Mi'kmaq territory, and I really appreciate learning that this land that we are on in Toronto is subject to a number of treaties, including Treaty 13, Treaty 13A, Treaty 19, and the Williams Treaty. And before there are covenants with the Crown, these territories are subject to the Dish with One Spoon Wampum Belt Covenant. And that covenant was between the Iroquois Confederacy, the Ojibwe, and allied nations to peaceably share and care for the resources and land around the Great Lakes. And really to reinforce and appreciate that in these covenants, in these treaties, we are all treaty people. We are all bound by and influenced and meeting the obligations of those treaties. So again, to acknowledge the particular members of the working group for the priority populations and to thank everybody for their engagement. You'll see the logos of all of our organizations. For the BC Centre for Disease Control, CADI, Canada's source for HIV and hepatitis C information, the Canadian Aboriginal AIDS Network, or CAN, the Canadian Liver Foundation, PASAN, the Prisoners HIV/AIDS Support Action Network, Sick Kids, and the South Riverdale Community Health Centre. So Jason and I are going to take turns during presentations. You have a piece of paper in front of you that gives you all of the names of the individuals who began the writing process, began the work of offering some guidance. We're looking forward to your feedback. And Jason's going to explain more about our process.
So here's what we've been doing for the last few months as a group. So collaboratively, we identified priority communities, priority populations. We highlighted the key principles and recommendations that we want to see applied to the development of this blueprint, regardless of what stream folks are talking about. So if it's treatment, prevention, screening and testing, we want to make sure that these principles are embedded throughout, and that was really our primary goal for making sure that's integrated into the blueprint for a national plan. Our intention is for these recommendations today to spark discussion, not just today, but throughout the process of developing and designing this. To date, we've identified the seven priority populations, and for each of those, we've taken time to not only look at who the community is, but synthesize what the burden of disease and specific issues are for each community, to identify the key principles and recommendations, share the findings with the other groups that are working, and review the targets from the working groups as they're emerging with a lens to making sure that these considerations from each priority group are being considered. And our other commitment was to reach out to the groups that we're connected to be actively involved in the consultation process. We're going to continue to review everything that emerges in the blueprint, but also continue to reach out to make sure that engagement happens in a good and meaningful way. This is the first opportunity for a face-to-face engagement, and we recognize that it's maybe not easy for all folks to participate. So our commitment is to make sure meaningful and deep consultation happens throughout the process as we move forward. So really brief, I'm going to be brief so we can get to the meat of it and get some feedback. But basically, the communities and priority populations we're talking about all have increased vulnerability and burden of disease for a variety of reasons and have barriers to accessing healthcare services. There are unique contexts in addressing the needs of each of those. And really, these barriers to the system can include stigma and discrimination, geographic boundary barriers and spread, cultural barriers, knowledge barriers. And I think one of the things we wanted to note that is we talk about these distinct communities or populations, and that's the epidemiological speak for communities. It's important to recognize that people don't think of themselves as populations. They think of themselves as members of communities in diverse ways, and that the success of our efforts to address population health needs will be based on successful community development approaches and successful ways of engaging communities in these dialogues and in these solutions as members of communities. And I think just making sure that as we apply an epidemiological approach, we don't lose the essential opportunity to make sure we're embedding that in a meaningful community development approach. And that was the other part of what we're trying to achieve through this working group, and that these communities, it's also essential to recognize the intersectionality and interconnectedness between these, what seemingly are distinct communities. And as we go into some of the details about the priority groups we're talking about, some of those intersections become very obvious and that you can't separate one from the other. And I think that deep connection across some of these seemingly distinct populations needs to be in the frame as we move forward. These are the 7 specific groups that we were looking at: people who use drugs, Indigenous communities, people who experience the prisons, men who have sex with men, gay and bisexual men who have sex with men, older adults, immigrants and newcomers, and children and youth. And you will see that there are some really big differences in terms of some of the existing evidence and data that we have. So the overarching principles, again, are specifically to make sure there is a targeted approach for each of these communities and populations in the national strategy. For some populations or communities having specific streams within the strategy, we really wanted to make sure that the principles of nothing about us without us were adhered through the process, and that there would be ongoing meaningful engagement with communities, and that the approaches need to be tailored, specific, relevant, and sensitive to each group. I think one of the dangers is having a one-size-fits-all approach, and Jordan talked about that earlier. We also need integrated approaches that don't just address Hep C, but address the broader social health and human rights issues that are faced by the communities we're talking about. So we're going to go through you have the document in front of you of our draft, which we really do want feedback on. We're going to just touch on some key highlights from each of the communities that we've been pulling together.
Thank you. Jordan, you did such a fantastic presentation that we have actually got halfway through our slide set before we were even meant to start on the agenda. Fantastic. So I'm going to slow down a little bit and just acknowledge, so a couple of things. As Jason's mentioned, you actually have this resource in front of you, so you can follow along as we're talking and as we're sharing. I'm going to read, and as a presenter, I hate reading, and I apologize profusely. However, because we're working with priority populations, because we really want to be respectful of each other's voice, we have very, very carefully, as a working group, reviewed the language and the terminology and the way that we're presenting. So I want to honor that very careful editing and attention to detail. So forgive me, I'll try to look up as much as I can, but I'm also going to read along to balance that important, respectful approach. So when we're talking about Indigenous peoples, up on the screen you have some of the highlights and important considerations we want you to bear in mind. That HCV infection is 5 times higher amongst Indigenous populations. That racism, colonialism, and systemic abuse is a key driver to that reality and is a key part of the context in responding to hepatitis C. There's a great diversity in culture, geography, language, socioeconomic statuses, and governance across Indigenous territory in Canada. And when we use this term Indigenous, it's meant to be inclusive of people who identify as First Nation, as Inuit, and as Métis. And we're thinking of people who live in urban settings as well as on reserve and in rural settings. And we know that Indigenous-led and culturally safe models of care will be essential to success. So when we think about the burden of disease, there's limited epidemiology available, but we do see this comparison of 5 times greater. When we began to sit down together and talk about our priority populations and those intersecting factors, we really wanted to highlight that Indigenous peoples are not inherently genetically predisposed to hepatitis C, that there are in fact very complex intersecting environmental factors and contexts that increase risk, and that Indigenous peoples are overrepresented in many of the other priority populations that we're going to be speaking about today. When we thought of key considerations, key aspects of a response that might be important to consider, we really wanted to highlight that trust is a key consideration. Trust in a system, trust in being able to access and receive good care, and where that is lacking in Canada, that has an impact on how we treat and respond to hepatitis C. that care that is Indigenous-led and culturally safe is most effective, and that we have limited numbers of Indigenous leaders and healthcare providers in the field. And often, those people are asked to be involved in many responses to diverse health issues, and so it puts a burden on the response. So while we advocate for Indigenous-led, we also have to acknowledge and understand that that leadership comes at a cost to the community. When we want to look at recommendations and imagine how we might move forward, you can imagine, and again, as Jordan very eloquently described this morning, you'd make a choice between a syndemic approach and a specific approach. When we talk about priority populations, we make a choice about a pan-Canadian approach or an individual population approach. So we've offered recommendations that are particular to the priority populations that we're speaking about, and that we hope will also contribute to the broader blueprint. So we want to see a specific focus, implementation strategies for Indigenous populations in national and provincial hepatitis C strategies, to use a health equity approach across the hepatitis C cascade of care, and establish high targets of health. We're going to reach high, aim for high quality health, not the bare minimum, not the same as everybody else, high quality of health. That we want approaches that will be Indigenous-led, multidisciplinary, and rooted in Indigenous determinants of health, again, recognizing the impact of colonial racism and social exclusion. And that shared care models of healthcare delivery can be very effective. Care models that include primary, mobile, community-based, e-health, and other specialist support will be most effective. That culturally safe approaches and resources have to address holistic, collective, and intergenerational trauma. And that when we build community awareness and readiness for hepatitis C programming that includes harm reduction, we'll have to also be aware of addressing the broader community needs and not hepatitis C in isolation.
So the second community that we focused on are people who use drugs. And I just want, before speaking about the burden of disease, et cetera, I think the image we chose for this slide was intentional, and I just want to note that in the current overdose crisis that we're in, it's been hard at times for those of us who are deeply connected to drug use and drug using communities to stay focused in a positive way around goals like elimination or significant reduction of hepatitis C burden. And that our conversations have shifted a lot over the last couple of years to are we going to have anybody left to treat in the current context? So I want to acknowledge that because it's been a challenge. And a couple of years ago, for those of us doing Hep C work with people who use drugs intentionally, we entered a period of incredible optimism as therapeutics became available, barriers started getting reduced to access those, and then we have this massive overdose crisis happening at the same time. And so I want to acknowledge the losses that the community has in presenting on this. We have to acknowledge the losses we have experienced and that the communities we're working with have experienced. And it has been a hard time to remain optimistic about these elimination goals. Having said that, it's also important to recognize that in our context, Hep C is absolutely most prevalent amongst people who use and inject drugs compared to all other groups. 2/3 of people who, at least, conservatively 2/3 of people who have experience with injection drug use have had past or current Hep C infection. And that's a conservative estimate. We can't talk about addressing the needs of this community without addressing the criminalization of drug use and people who use drugs and the barriers the criminalization creates. The intersection of drug use and being part of the prison population and community and that connection, the significant overrepresentation of Indigenous community members amongst communities who have been criminalized and are part of this community need to be acknowledged as well. So as well as probably the fact that the boomers that we're talking about at some point have a drug use history. So I think that we need to acknowledge all of those things. Along with the other social determinant of health issues that people who use drugs as a result of criminalization face, including homelessness and poverty and systemic discrimination in the healthcare system. So we could do a whole day on this, I think, as with every other community, but I want to acknowledge those things. So those intersecting factors I mentioned, criminalization, increased increased lack of access to prevention and harm reduction through criminalization and all of those things. The other key considerations is, depending on where you live, access to harm reduction is extremely unequal across the country, in rural, non-rural, and even in suburban neighborhoods. We're also seeing in cities like in major urban centers displacement of people who use drugs, and then a loss of access to harm reduction services. Just speaking locally, we've been really focused on the effects of development and gentrification in the downtown core and the push of people out to the inner burbs where there isn't service infrastructure, their loss of access to harm reduction, increased overdose risks, increased infection risks. All of those things are happening both at a rural, suburban, and urban level as development happens in urban centers. Services and treatment availability becomes less. It's been well documented that stigma and discrimination against people who use drugs continues to create significant barriers to all areas: prevention, testing, and treatment. We know that many physicians remain unwilling to treat people who are active drug users, and that the increased risk of reinfection and death remains very, very high for our communities, and it isn't getting better. So the recommendations that you will see in here include a need for comprehensive, accessible harm reduction programs to support prevention and reinfection, testing and treatment that should be adapted to and delivered where people who use drugs already feel safe and receive services, whether those are harm reduction programs in prisons, in Indigenous health services, community-based primary care settings, et cetera. Treatment needs to be accessible for all, regardless of current drug use. Hep C treatment should be considered within a larger context of drug user health and health services that is not just focused on infectious diseases. And if we don't shift that focus to be broad and inclusive of the healthcare needs of people who use drugs, we will continue to fail. And lastly, going back to nothing about communities without people who use drugs must be involved in the design, delivery, and evaluation of the services that they receive. And we've seen, we know the evidence supports that as well.
Thank you. So thinking about people with experience in prison, and again, highlighting 1 in 4 prisoners has or has had an HCV infection, that often HCV is transmitted through unsafe tattooing, piercing, or drug use. Harm reduction is a key strategy to offer support, and we must improve both screening and treatment in prisons. So when we think of burden of disease, we know that people who enter the prison system already have a higher risk of hepatitis C, and that their time in prison can further increase their risk due to poor access to safe drug use and safe tattooing equipment inside. When we think of intersecting factors, and you'll hear that we're beginning to echo each other when we know that statistically and through our organizations, through our work, through our community connections, that people who use drugs, Indigenous populations, are more likely to have experience in prison systems. When we think of those key considerations, those things that as a working group we wanted to say to our other working group colleagues, please bear this in mind, that treatment in a prison setting is difficult to access due to interruptions in benefit programs, that while in prison, and there's also difficulty getting a referral to a hepatitis C specialist. There's a lack of support for harm reduction and for drug withdrawal management, which increases risk. And when we think of recommendations, again, we want to see specific attention to the needs of people who have experience in prison. We need that at the federal and provincial level. For prevention considerations, for recommendations, we want to see the development of programs and policies that support harm reduction in prisons, including supplies for safe tattooing and drug use. And by the way, that might mean reinstating the harm reduction programs that Correctional Services of Canada had already tried out, including safer tattooing practices as a pilot program. We have the wisdom. For screening and treatment, to address and evaluate inconsistent policies and procedures that we can then identify concerns and improve access to screening and treatment. And to provide overdose training and make naloxone available to prisoners and correctional officers, again, in that context of a harm reduction framework.
The next group that we're going to talk about is immigrants and newcomers to Canada. And again, as many in the room already know, some of the background in terms of the burden of disease. 20% of people living in Canada are foreign-born, and immigrants and newcomers to Canada represent 35% of all past and current Hep C infections. Again, that's the estimated amounts. In terms of newcomer communities and immigrants and refugees, the bulk of transmission was through unsafe medical and dental practices in their home countries. Transfusions, reuse of improperly sterilized equipment are significantly the cause of infection. But it's important, again, to identify intersecting factors. Immigrants and newcomers are also likely parts of other priority communities that have increased risk, and may be less likely to disclose those for fear of stigma and discrimination within their own communities, but also within the healthcare systems that they intersect with. And I think that is probably an under-recognized fact, but it needs to be pointed out. Key considerations: hepatitis C is not routinely screened as part of the immigration process, so there's a likelihood of, again, under diagnosis and under knowledge of status. Immigrants and newcomers are less likely to access healthcare systems than Canadian-born residents, and particularly for folks whose status is uncertain or in the transition between becoming landed and full citizens, the healthcare system remains an intimidating place to access in a variety of ways. In addition to that, cultural and linguistic barriers create significant barriers to not only the healthcare system, but good healthcare information and health information. There are particular barriers for non-status, undocumented, and illegal immigrants, and this represents an important subgroup. In Ontario, community health centres like ours actually have a particular mandate to serve that community. We can test folks, but the cost of treatment remains a prohibitive barrier if we find out that people are Hep C positive and they are undocumented or illegal, and that remains a significant barrier for more and more folks as migration patterns are shifting and people are actually, at this point, fleeing relatively safe Western countries like the United States and walking over our borders. Fear of deportation and the immigration system keeps people out of the system. So our recommendations here are to create a specific focus on immigrants and newcomers in the strategy, look at screening and testing and linkages to care, ways to make those more accessible to newcomers when they first arrive, as well as good quality and accessible information on Hep C and testing as part of newcomer primary health care screening. So the base screening that people get, even in good primary care designed for newcomers, can be improved. We need to do some education with healthcare practitioners to increase hepatitis C risk and awareness and the benefit of screening for newcomers, and integrate screening and treatment into the community-based models of care that are most accessible to these communities. I'll leave that there. Apologies for the very gendered representation.
So we've heard an awful lot in the news in the last week or so about older adults living with hepatitis C, which is fantastic and perhaps will be another entry point for greater discussion in Canada in response to hepatitis C. So when we think about older adults, we're talking about those who are perhaps over 40. So we'll gently consider the older connotation, perhaps. But really, looking at a cohort of people born between 1945 and 1975 with the highest prevalence rates compared to other age cohorts. And this age cohort is 5 times more likely to develop hepatitis C complications. So thinking about cirrhosis, cancer, premature death. And this is compared to the general population. And then when we think of chronic hepatitis C, it's the main cause of liver transplants. 98% of hepatitis C liver transplants for people aged 40 and over related to hepatitis C. Phenomenal. When we think of intersecting factors, older adults are also part of the priority populations that we've already discussed and introduced, and this can increase their risk for hepatitis C again. And in a key consideration, transmission is mainly a result of medical or hospital procedures or past drug use. So I know when talking to my mom and saying, you should get screened for hepatitis C, or in this older age group category, she's like, well, I've never had a risk. I'm like, it's not about risk, Mom. It's just about being wise. It's about knowing this is important. It's important to be screened, have one test, know your status, look after your health. It's very, very simple. When we think of recommendations, again, we've heard fantastic recommendations across Canada now for one-time testing, should be done to capture undiagnosed cases. And this would be in addition to ongoing risk-based and clinical-based screening. So again, for those who continue to be at risk, we continue to screen. Thinking about screening and treatment recommendations, that we must provide education and support for healthcare providers, for providers to look at our older adult patients and recognize that the care that needs to be delivered, regardless of assumptions that might be made about somebody's current or past history. And particularly around screening, to be mindful of comorbidities and advanced liver disease. And we want to increase community awareness on the benefits of screening for older adults. Keep the media attention going. Thanks.
Gay and bisexual men who have sex with men. So in terms of the burden of disease, 5% of men who have sex with men are antibody positive for Hep C and are an emerging population. In terms of transmission, sexual transmission remains a significant and under-discussed likely cause. I think in terms of intersecting factors, though, it's important to recognize again the overlapping nature of things people do, including sex and drug use. And so that is an intersecting factor that should be paid attention to when looking at key recommendations for this community. With, one of the other considerations are, the emergence of PrEP and PEP and strategies for HIV prevention, which may reduce condom use in community, where as a result of those massive advances and the need for increased awareness in the community about hepatitis C risk. There is less awareness of the need for Hep C testing amongst gay bisexual men compared to HIV and other STI testing, where there is a greater awareness at this point. Our recommendations include to improve awareness and knowledge about hepatitis C prevention and testing in the community, integrate Hep C testing with into existing gay and bisexual health strategies and HIV strategies and programming. So some of this is happening clearly, but there's a feeling that we've been slow to this conversation, slower than we needed to be. So this remains a distinct community that we've focused on with those key recommendations as a small amount. Have you guys all noticed that you get 10 years to be an adult now when it comes to health? Like you're in the youth category till you're 30. And you get 10 years. I'm aging out of the adult population this year and into the older adult population. And so it's a disturbing lack of time to actually be considered an adult. That isn't part of this consultation, but it worries me. Anyway. I feel it's actually eroding my mental capacity.
Fantastic. So here we are in our 7th priority population, and again, we're presenting these in a somewhat logical to us, but random order in terms of there's no prioritizing of the priority populations. So thinking of children and youth, and again, recognizing that there's not a great deal of data available, so the epidemiology is somewhat unclear in this population, and therefore we need to know more and learn more. And that there's an increased risk for children whose mothers have hepatitis C. When we think of intersecting factors, there's an increased risk for children who are immigrants or newcomers, including international adoptees, children who are Indigenous, children and youth who are street involved, and children or youth who have parents who use injection drugs or are street involved themselves. Key considerations in this population, there's a lack of awareness and knowledge within the hepatitis C medical community on pediatric hepatitis C. There's a lack of recommendations for screening. Funny how those two things might go together. And for understanding when and how to screen for high-risk pediatric groups. And a need for family-centered care to provide care for children with hepatitis C in partnership with the child, the family, and healthcare providers. We need age-appropriate education resources for children to understand risks, the clinical course, lifestyle modifications, and for treatment. Teens, particularly street-involved youth, may require a unique skill set or a framework for effective communication and care delivery. And there's delayed access to new medications compared to adults, and some medications will not be studied and approved for children. So all of these considerations and factors influence how we might imagine going forward with a blueprint for action. For our recommendations, we want to see increased awareness among the general public and healthcare providers of hepatitis C about the risks for youth. In regards to testing, to create guidelines for screening children for hepatitis C, particularly for children who may be at higher risk. For screening and treatment, develop practitioner skills in communication with teens, family-centered care, age-appropriate patient education. And we need to see the approval and funding for antiviral therapies for children and youth. So now we get to the interactive part of our program. And really quite sincerely, this working group, Jordan, thank you for the acknowledgement and for your leadership. We have been meeting frequently. We have been emailing even more frequently. We have been writing and sharing and trying our very best, but we're well aware, we're all well aware that in this context, we're going to forget something, we're going to miss something. There's something obvious that should have been written down here, should have been presented. So we really appreciate and need your feedback. This is an opportunity to influence elimination of hepatitis C in Canada. So we welcome your feedback. We appreciate constructive criticism. Thanks. I think we need, sorry. So we probably need to ask you to stand at the microphone so that it gets recorded.
So that we can record.
I know it's awkward, but.
It's a small room. So the one thing that I didn't mention that I do want to mention, first of all, I would really like to thank Melissa and Jason who have sort of chaired this working group, and all the members. But I also, the reason we started with the priority populations group today was that we hope that this will give a context to sort of framing the other discussions. That's why we wanted to sort of lay them out, and then you have that in your mind as you think about each of the other presentations. And I meant to say that earlier, but Curtis, a question or comment?
So thanks for that. I thought it was a wonderful combination of the facts plus the human impact that all of this is having on people countrywide. On the immigrant and newcomers section, you stated that 1 in 3 individuals had current or past exposure to Hep C. Just wondering where that came from, because that seems really, really high, at least from my point of view.
That's not what he said. Like you said, about 30%.
No, it's of people with hepatitis C. Yeah, of people with hepatitis C, 35% of them are from another country, are foreign-born. So it's not that of people who are foreign-born, 35% have Hep C. It's the other way around.
The burden of Hep C in Canada.
Right? Does that make sense?
Is found in is estimated
Yes.
to be. It still seems high.
Yes. So Naveed can speak to that.
So, and similar to other population groups and other areas, so this is an area where we don't have a very good handle on disease burden, and this requires further work. But this is what is available based on some of the data that was compiled.
Well, but it highlights an important point, right? I mean, we only have limited data, so we some of those statements can be quite concerning or quite profound statements. So this is the call for better data and for caution with statistics and for awareness that where there's where there's already something that's rising up as a key population, then obviously something needs to be done and attention is required, and perhaps those stats will change, but it needs it raises the bell.
So just sticking on this priority population for another moment, with working in community health centers and working with populations of individuals who are refugees or who may not have status in Canada, I've recently come across individuals who are being deported because they have been newly identified as having Hep C, and the Canadian system has said that, it's too expensive, this is too high of a burden to treat this individual. So I think that it's really important when we're looking at outreach testing for individuals who don't have permanent status, that we have to look at the risk associated with that, and that the risk of deportation is actually a significant risk.
I was actually about to raise something similar. I don't know about deportation. I mean, it can occur, I think. I think in immigrant, we have the same issues that occur, for example, around HIV testing, which is obligatory for all new immigrants since 2003. And immigrants and refugees are not going to be sent back based on a positive HIV test, but it does require quite a lot of work on the healthcare provider's side to justify that they will not be an undue burden to Canadian society. So as prices come down in the costs for treatment of hepatitis C, hopefully that issue becomes less of an important one, but it's a real one, because from a public health perspective, I think the answer is very clear. You need to screen like we do for syphilis, HIV, and hepatitis B. We should be screening all immigrants and refugees for, no, we should be. Yeah, we're not. We screen for TB, HIV, and syphilis, but the other ones we don't, and these have major public health impacts and burdens of disease for the individual. But it has to be balanced with this concern about stigma and just potential impacts on their being able to stay in the country.
So this is a bit of a theme here. In British Columbia, I've actually been involved in preventing the removal of 2 individuals because of hepatitis C. Newcomers that didn't have coverage, where the families were able to subsidize the hepatitis C treatment, were able to advocate that once they're cured, and they had very mild degrees of fibrosis, and they weren't going to be a burden to the healthcare system. And I think a point where we can sort of at a blueprint level emphasize some of these issues is that a lot of this is federal. We talked about jurisdiction at the beginning. So if we're going to do some things that might have short-term impact, the federal process is directly involved, and these could be direct recommendations that way. And one other quick point, coming back to people who inject drugs, is there may be an argument to be made that by engaging people in care for their hepatitis C, this might have a significant impact on the overdose epidemic per se, meaning that as they get engaged, they get a bit safer, and we reduce some of the risks that are associated with their drug use. So making that argument as part of the blueprint might actually enhance its credibility. Not that it needs enhancing, but another point to make.
Excellent job. I was just thinking a little bit about including in the documents the notion of the structural and policy barriers, which there's overlap between the different subpopulations. And they need to be sort of articulated, because fundamentally you can treat or you can cure, you can do certain things, but in order to get there, you're going to have to overcome those structural and policy barriers. And that needs to be added, I think, into the document.
2 points related to immigrants and newcomers. So this is a very important point with respect to preventing people from coming into Canada because of their infection status, or removing people from Canada because of their infection status. A lot of discussions that have happened over the past few years, I have been against screening people before coming to Canada because of this very reason, that this could be used as an instrument for not letting people in. And certain countries have higher disease burden, and they could be discriminated against. So that's very important that we highlight that in the document and bring it to federal government for their discussion. And based on some of the discussions that we had at CAR earlier this year, Immigration and Citizenship Canada, they highlighted that they don't make decisions based on these issues, but I think we need to put that in writing and get a commitment from the government that there is no discrimination based on infection status of a person. Second issue that I want to highlight, which is more related to delayed diagnosis and screening, Curtis and Chris Greenaway from Quebec, Curtis from Ontario and Chris Greenaway from Quebec, and then we in BC, we all saw the similar trend of delayed diagnosis between 10 to 15 years after arrival in Canada, and that highlights lack of testing, and that puts more burden on the healthcare system rather than less burden on the healthcare system, and that is very important from immigrants and newcomers' point of view. Thank you.
Hi. 2 comments. First, I really appreciated your emphasis on the difference between epidemiology and communities. And I just wanted to acknowledge that I really appreciate you recognizing that people consider themselves community members first. And I was also wondering, there's statistics from St. Joe's that show that people who are experiencing homelessness are 25 to 28 times more likely to have hepatitis C. And I was wondering why they were not selected as a priority population. I know that they will often fall in some of these other priorities, but I know that in my community, people who are experiencing homelessness face specific barriers around transportation to get to appointments, and not having an address to get your, like where I am, the prescriptions are mailed to the people, so they actually can't receive their they can't receive their treatments in the mail, and that's the way that they're delivered in my area. So I know it's a little late in the game to be bringing forth another priority population, but just wanted to. Okay.
It's not too late to do anything. I think that's the point of this. Actually, is that it's a draft. It is a draft, and I think where homelessness is flagged as one of those intersecting factors. But absolutely, it's when you say that, it absolutely could be a primary way to organize how we think about. And if we think about the structural barriers that were raised as needing really explicit. Outlining what those structural barriers are and at what levels, it feels like those things may actually come together both as an overarching piece, but it may be meaningful to reorganize the way we're identifying communities. So we should take that away. I mean, I'd be curious to know if, by a show of hands, how many people would think that should be based on where they sit and where they work and what they do, or their community they're in. Does that make more sense than this organization that we have now, or in addition to, as a specific community?
I would
say yes. In addition to. How many people would say yes? We should add homeless people as a specific community. Yeah, there's a lot of hands. So I mean,
yeah, I can.
Yeah.
Definitely deserves a mention
Yeah.
in the document. I don't know how if you parse it off as a totally different community, but clearly there's different barriers and challenges, right? Yeah.
We can work on it then. Yeah.
So I want to move to another one of the priority populations, either the more age-based ones, because if you look at the ones that we've highlighted otherwise, I think they've all been recognized to fit into those who would be perceived at risk and would be already sort of in most, with the exception perhaps of the immigrants and newcomers who have been sort of left behind in the testing side. The older adults in particularly clearly have been left off the, at least the current guidelines for screening in this country, and we're meeting with resistance around that issue. And I know the CMAG guidelines that were finally just published had come out against that. But I think we need to think strategically. It only took, I don't know how long, strategically about how do we actually move that forward, because it's clearly a gap. And it's like this kind of head in the sand sort of attitude that we just don't want to know. Now, maybe with the prices, I mean, one of the arguments seemed to be around the fact it would be just too costly, either from the diagnostic testing perspective or the treatment perspective, to discover all these people. I don't know, which seems a bit counterintuitive given the healthcare costs associated with delayed diagnosis. But I think we need to think about how we can position that better so that it's convincing to the players that are involved.
Yeah, that's a good point about sort of providing some type of evidence behind the recommendations where it's possible. One thing I'm just going to ask, and just as a minor housekeeping thing, if everyone can just identify themselves and where they're from when you go to the mic, just so that, because a lot of the people in the room know each other, but not everybody does, and it's helpful. Thanks. And also for the recording. So.
My name is Zoe Dodd. I work at South Riverdale Community Health Center. I'm always struck by the whole older adults, because I think it gets back to about specific communities and that older adults overlap. So you can be an Indigenous older adult, a man who has sex with other men, and be an older adult. So I always find it interesting because you're not a priority population, really. What commonalities do you share except for age? And so and also, I think one of the things we continue to do is continue to create immense stigma when we say that an older adult used only once and that was their risk behavior, when older adults still continue to use drugs. I also just wanted to highlight, I'm glad that Kapud is invited here. I will say, even though my friends are on the working group, that it is an oversight not to have involved the Canadian Association of People Who Use Drugs from the very beginning. And just to add in pediatric, sorry, I'm just looking at pediatrics. Just the pediatrics and teens, I think you put them together, but I think the biggest risk we don't actually say that the risk is that people use drugs. And that also you don't have this highlighted in here. You say that there's street involved. And I think that's important to say that young people use drugs. And there's nothing here that says that people need access to harm reduction, and age restrictions are some of the biggest barriers to to children and youth who need access to harm reduction and also to Hep C treatment and care. So another community of people I think we often neglect to talk about is people who use alcohol. We talk about drugs, but we have a lot of people who access our services and go to hepatologists who are using alcohol, who, have a struggle getting access to Hep C treatment and care. And on the onset of talking about recommendations, and you talk about people who use drugs, I think we should say that many specialists are unwilling, not physicians, to treat, because I think we need to acknowledge the past history, the continued history of specialists refusing care to people who use drugs. We don't have that many primary physicians. It's confusing. I know that a specialist is a physician, but I think we need to be very when we talk about bringing people into care on the overdose crisis, how many people did we discriminate against who then that contributed to their negative self-worth and all those other things that has also contributed to the overdose crisis? So I think we all play a responsibility in that. So thanks.
Thanks. And I'm glad that CAN, Hep C, and Kaput get to meet. But yeah, with apologies for it happening, also I think you're with apologies for it not happening sooner. But. About the age code, please, Jordan. Yeah.
I mean, I think it's an important point, and I think we've struggled with this a little bit about thinking about how to even just with this sort of testing push for baby boomer testing. And I can say that one of the arguments that I would put in favor of sort of baby boomer testing is to destigmatize testing. So to not necessarily link hepatitis C with any behavior or anything else. And I mean, there's pros and cons to that, because on the one hand, I think you might say, why not just destigmatize drug use at all and have no negative connotation to that? On the other hand, and there's pros and cons to either strategy. I think one of the reasons that we thought about this as a priority population is that it's a large group of people living with hepatitis C, and there's no question that all of these populations have a lot of intersectionality. There's a lot of crossover between them. So they're not mutually exclusive, but there are ideas that are maybe more relevant in one context than another. So I mean, there's pros and cons to doing it any way you do it, but I
guess I would say just stop saying that you may have used drugs once. If everyone could just stop saying that about older adults, I find it so offensive. It's oh, so you used once, so you're the better drug user than everybody else who's used throughout their lifetime or 10 times. So I would just say I've heard that the whole time I've been in Hep C the last 15 years, and I just love us all to stop saying it. And also men who have sex with men, I just forgot to mention that men who have sex with men also use drugs, and we talk about sexual prevalence, but where is the prevalence about actually using drugs? And we don't talk about other LGBTQ communities who we don't have that data to say oh, gay women also have a risk because they're using drugs. So our epidemiology is such garbage that we don't know what the evidence is, but we still use this thing, and what we're saying is your risk is sex, but we don't actually know that if that's actually the truth or if it's from injecting crystal meth. So I think we still say this thing, but we're also saying we're actually creating this thing where we're not actually saying harm reduction, drug use.
Well, there is a specific mention of drugs use in the context of sex in the gay and bisexual MSM population.
Likely cause, but I'm not sure if we can actually say that it's actually a likely.
Say more strong.
Yeah, more strong. Yeah.
More strong. Okay. Yeah. Fair.
Curtis Cooper. I'm an infectious disease specialist from Ottawa. So at CAR back early in the spring, we had a symposium on immigrant health, and we talked an awful lot about hepatitis C. And afterwards, one of the very strong comments by one of the participants to me was, "You can't screen; it's going to increase stigma. You're going to create harm." I don't agree with that point of view, but I certainly see the point, and that comment has actually stuck with me a couple of months later. So I know you've probably thought about this, but I'm wondering if you could comment on that. And I'm sure in the document you're going to, with all of these populations, with any efforts to screen, addressing the potential harm through stigmatization needs to be front and center and considered in any approaches that are being taken to that.
So the short answer is yes, and I think that, I mean, that's the overwhelming feedback is, and I think it speaks to these not only structural barriers, but the impact of engaging people in screening if you can't provide care, or if what are the consequences of engaging people in somewhere in the cascade if you can't move them through either, right? There's a whole bunch of pieces, or if it mobilizes other systemic factors that create more risk for them. So I think we need to put that, some of that overarching stuff needs to be in here for all of these communities that we're talking about. Then there are some differences, but similar issues around criminalization, et cetera, right? Like in different ways. So I don't know if anybody who had a primary role in writing that section wants to comment. Who's in terms of the newcomer and immigrant. Yeah. Okay.
Hi, a very quick comment. It's Lisa Barrett from Halifax. I don't want to get us too far off time. A very succinct guy yesterday, a patient actually, who was involved in a meeting, who has lived experience with hepatitis C, looked at me and he said, "Be very, very careful, Lisa. Every person is a priority." And I think as we go forward and think about priority populations, we don't want to shoot ourselves in the foot by not remembering that every single person is a priority. And I don't know how we message that, but I'd love to hear what people from the community think. And just to remember, I think that every person is a priority. And when we say those words, sometimes it gets taken a little offside when it's seen as a short title. So that's number one. And number two, when it comes to the testing concept and testing of baby boomers, it's not actually the cost anymore that I hear very much about when I talk to governments and to policymakers. It's an awful lot about, oh, well, we can't test people until we have a process of getting people engaged in care because we'll cause harm. And I think that this document and process is exactly the tool needed to come back to respond to that. So this whole process of having a plan in the provinces is exactly the tool we need to kind of reply to that sort of, don't test people because we can't engage them in care. It's like the pharmacy-based strep testing. Well, they can't get engaged in care. Well, actually now we have a plan for Hep C, and I think that's really important.
Mel Crashton, British Columbia. I'm just thinking a little bit about what Jordan said in syndemics. And syndemics is a lousy term because it's an academic term. But if you unpack it, it's really about recognizing that people just don't have one issue, they have other issues. And as was just pointed out, every population is a priority population. And every different person or population or community has a bunch of needs. And somehow we need to be able to embrace the fact that these needs need to be met by our system. And hepatitis C is just one of those component needs. And my sense is this federal framework does fit into our real world, our modern world, that different people need these different services. And just curing someone for their Hep C and not giving them the wraparound services is the wrong thing to do. Just screening someone for Hep C who's an immigrant and not screening for Hep B doesn't make sense. So we have to be able to navigate this really complex territory because the decision makers will be trying to think through those things, including the point that Lisa brought up, which is, okay, when you screen them, where do they go? How do we put that together?
Brian Conway from Vancouver, and I'd like us to think a little bit about who we call old. When you talked about baby boomer screening, that's certainly one aspect, sort of the 45 to 75 group. But some of us still use the benchmark of 65. And the reason why it's important in Hep C is that in many of the clinical trials where we evaluated the efficacy of the medicines, people over 65 were excluded. So now at the academic meetings the last year or so, there have been real-life studies of people over the age of 65 who have been treated to show that they are just as effective, and there are no new side effects. So that's a population where some have thought, well, we don't know if the treatment works. We don't know if we should test you or treat you. So to sort of think about which way we want, both are correct, obviously. We want to sort of highlight certain types of populations, but just to maybe have a little subgroup of the older population that aims at that, to remind people that yes, they may not have been in the clinical trials, but in the real life cohorts, a lot of these people were treated and it worked, and we should really go after them. So to highlight that as maybe a subgroup of older.
Good point. Can I just come back to Lisa's point about the priority term? Because this was a major issue when the AASLD guidelines, treatment guidelines came out, and they initially used the term priority for treatment, and they talked about people with advanced fibrosis. And I can say, as someone who sat on the guideline panel and strongly said, don't say the word priority because it will mean they won't treat anyone else. Are we going to do the same thing here by using that term? I kind of don't think so, because I think what we're doing here is framing, the purpose of having the populations we're describing is to sort of make sure we frame the other recommendations with those populations in mind, rather than saying these populations should be addressed first or foremost or anything else. But I really do think it's an important question. I would just, because that's a really big fundamental change. If we're going to change that name or that structure, if people feel like we shouldn't be using that term or should be using a different approach, that would be an important thing to discuss today.
Lindsay from PASAN, Provincial Hep C Program Coordinator. Actually, I kind of wanted to just touch on exactly what you said. So for my personal opinion, working in the prisons, is that the way I look at priority populations is not by excluding everybody, it's by actually addressing communities that have been ignored. And the prison population has really been ignored and is not really included in certain conversations because it is pretty, it's stigmatized in general, right? Like just the prison culture. So for me, I think the priority for the prison population, I'd like to keep it in a priority because it hasn't been addressed, and it's still going to be a struggle to address, even with this national strategy, like Hep C strategy, just because in the prisons, it's care, custody, and control, right? And so if we're talking about engaging people, not everybody in prison can actually engage in their healthcare or has the ability, even though they want to engage, through requests, through behavior, through certain charges, that your healthcare is actually not engaged from the jail to the person. The person has to reach out to engage that, but it's such a process, and there's so many barriers that come with that, that you can't always even access healthcare. Well, you can't do it successfully all the time in a prison setting. And I guess to Dr. Cooper, you were just mentioning about screening that sits with you about creating harm. I think even in the prison setting, that's a conversation, and that's why I guess having education and pre and post counseling within the jail setting, or even not even having the health, like the medical team doing the screening, bring communities in, have it be a community-based screening, testing, pilot project, I don't know, within the institution, because again, you have people that are sitting in jail that don't trust healthcare, that don't trust the prison setting, that don't trust the authority, but also confidentiality, right? Like if I'm getting screened inside, my confidentiality about my status is not a 100% guarantee, and that's a big reason why people may not engage in screening and testing inside the jails.
Thanks.
Yeah, I was just thinking about the key priority population question, and I think what IAS did was move to key populations, which is less kind of. But I think in our sense, we're really trying to prioritize these populations throughout the document. So we know that that's what we're trying to do, and that doesn't mean at the exclusion of others. Clearly, these are so intersecting. So I think we do need to give some thought to how that's perceived outside of our group. But yeah.
Hi, everyone. I'm Tracy Swan. I was just wondering to follow on what Marina said. We've since changed the U.S. guidelines to say key populations sort of in line with WHO and IAS. So I'm not sure if we want to think about how we structure this, that there are some essential things to working with members of certain communities, and these are a priority when we consider the framework of how services are delivered.
Hi, my name is Les from South Riverdale. I just wanted to point out that as an Indigenous man and a person that fits in a lot of these categories here, I find it offensive to say those populations of us are everybody's a priority. It's the same thing to me. I find it's like saying all lives matter. It's like you take so much out of what people have worked on, how you live your life, and how you've been. And I found that really offensive there. Thank you.
Les, can you? I really appreciate that comment. Can you suggest possibly a different way to structure it or to use language? Because I think one of the things that we're trying to do with this is to
try not to. Don't say that. Don't say everybody's a priority. It's as simple as that. It's the same as saying all lives matter. It's the same thing.
But what about the term priority populations? What about that?
Well, no, that like a couple of people here said. Those are key populations, what you're talking about.
Yeah.
Prisons, Indigenous people.
I see.
Those are the priorities that we're talking about here. Those don't fit in everything. Like the older population, the same thing is like, say myself, I fit in that category. Jason fits in that category. We're two different people when we have different things that affect us.
Yeah.
And so just to bring that out.
Okay, thanks.
Naveed Janjua from British Columbia Center for Disease Control. The way I think about whether you call key populations or priority populations, I think from the perspective of context and the needs for various services or suite of services that are needed for various group of people. So from that point of view, I think it's better to have populations. It's more what we call it, whether we call it key populations or whether we call it priority populations, but these populations need to be there because needs and the context are different and the suite of services that we need for each group of people may be different.
Okay, and that was certainly the intention. So, but when we came up with that term, so maybe just by a show of hands, priority versus key, just as a sort of a sense, who would prefer the term priority? Okay, who would prefer the term key? Oh gosh, I didn't count. It's almost 50-50. Okay, this is something we're gonna, I think we'll have to, I think this is something that we will have to keep in the discussion.
Disenfranchised, marginalized, and discriminated.
Didn't ask them.
You don't ask them what they want. So maybe you do want to stay prioritized, then that's the response.
Yeah. Are you considering them priority populations because they make up such a large amount of the people that we know are infected, or are you considering them priority because they need certain amounts of accommodations to bring them up to the level of equitable access as me?
I think it's a few things. I think it's potentially both of those things.
Okay.
So in
'Cause I think
these
that makes a
populations are
difference.
all have a higher burden of hepatitis C than many other populations. But they also, for example, children may not have a higher burden, but they have specific needs.
Yeah.
So I think it gets to Naveed's point about a suite of services that may not apply to everybody living with
Exactly.
hepatitis C, but they do apply to certain people with hepatitis C, and making sure that that suite of services is available to them. I think that's really the thinking behind it and how the terminology is, there's pros and cons to every term. But, I do want to, the one thing I do want to keep us a little bit on track of time. This has been a really helpful discussion and it will help inform all the rest of the discussions, but maybe we'll limit it to maybe max 5 more minutes before we go on, or less.
10 seconds. I think everyone knows this, but we discussed key versus priority in our first call. So key is used in the WHO manual, but PHAC uses priority, so that's why we chose that.
Okay.
So just the reason I would favor priority is I think in many of these communities, it's an emergency. And I think priority captures the emergency situation a little bit better than key. So that's, I'm just one person, but that's why that term it has more appeal to me.
Okay, let Julie, the last comment.
I refrained myself because I'll speak just after, but I just want to say that when you say priority and it's related to HCV, it may be a highly prioritized population in one section of it, access or screening, and for immigrants, for instance, in prevention, it's not a priority population. So I think the priority is a little bit problematic when you're looking at each of the section. Overall, it gives the idea that there is a lot of priority, but I think for me, it's more key because of that.
Okay, interesting point. I think we'll continue that discussion. So thank you to Renee and Jason for the presentation and for the very fruitful discussion. We're a little behind time, but that's okay.